Welcome to McTox Curriculum, brought to you in collaboration with Western University, the University of British Columbia, and McMaster University. This presentation is part of McTox Curriculum, built for residents and fellows from PGY 1 to 5. This module will be covering both neuroleptic malignant syndrome and serotonin syndrome. It has been created by Bandar Ba. By the end of this presentation, we will have covered the broad topic of the hot and altered patient, as well as the differential and treatment of hyperthermia. Starting with our first case. You have a 72-year-old male who comes to your ED with a 1-week history of fever and increasing confusion. The only medication he is taking is promethazine, and he is otherwise healthy. His exam reveals a confused elderly man with mild rigidity in his extremities, but no signs of meningitis. The heart rate is elevated, as is his temperature at 38.6. Your question to think about is, how would you approach this patient? This patient's primary issue is fever and an altered level of consciousness. It's a fairly common presentation to a variety of dangerous diseases with high mortality rates. With this type of presentation, it's critical to rule out a source of infection as you go through your differential. Therefore, a septic workup and early antibiotics should be strongly considered as part of the initial investigation and treatment. Since the hot and altered patient has such a broad differential, it helps to group them into 4 main categories. 1. Infectious, such as meningitis. 2. Metabolic, such as thyroid storm. Toxicologic causes, including ASA and NMS. Or environmental, such as heat stroke. This list is by no means exhaustive, but is a good place to start. Investigations that you order should reflect the different aspects of your differential and will be quite thorough. Pan cultures, urine, chest x-ray, TSH levels, ASA and liver function tests. A CK should also be considered to look for signs of muscle breakdown. After a thorough history, exam, and review of investigations, you make the diagnosis of NMS. This is a difficult diagnosis to make and relies largely on a high clinical suspicion. Its general pathophysiology is from a lack of dopamine acting on the neuroregulatory centers in the brain. This can be from the use of dopamine antagonists, such as antipsychotics, or from the withdrawal of a dopamine agonist, such as stopping a Parkinson's medication. NMS is a life-threatening condition that needs prompt recognition and treatment. As we mentioned, it's primarily caused by the use of antipsychotics, with the typical antipsychotics putting patients at a higher risk of NMS than the atypical drugs. The classic presentation of NMS is a combination of hyperthermia, rigidity, autonomic instability, and an altered level of consciousness. A combination of these symptoms should trigger you to think of NMS in your differential. Treatment of NMS is mainly supportive care in addition to obviously stopping the culprit medication. IV fluid should be provided, as well as vasopressors and sodium bicarb as needed. Active cooling should be initiated, as well as the use of benzos for sedation to manage the agitation and hyperthermia. Rarely, induction, paralysis, and intubation may be needed to prevent end organ damage from severe hyperthermia. All of the severely hot and altered patients require intensive care monitoring. Bromocriptine has been proposed as one of the adjunctive treatments for NMS. It acts as a dopamine agonist to tone down the dopaminergic effects of the antipsychotics. However, it should not be used as the primary antidote, as it takes several hours to start working. It's also only given as an oral medication, which can be a challenge to administer in a sick and confused patient. Dantrolene is another possible adjunctive treatment for NMS. It acts as a skeletal muscle relaxant by inhibiting calcium release from the sarcoplasmic reticulum. You may have heard of it from its use in managing malignant hyperthermia. Our second case is of a 36-year-old female who presents a day after taking an overdose of her fluoxetine, which she is prescribed for her OCD. Her chief complaints are diarrhea and altered mental status. She is tachycardic and hyperthermic on exam, and you can also elicit clonus and nystagmus. Of course, what we're talking about is a diagnosis of serotonin syndrome. This is caused by a sudden increase in serotonin in the brain, whether it's from an acute overdose, in the most common scenario, or a food or drug interaction. Like NMS, serotonin syndrome also presents with a varying degree of hyperthermia, rigidity, autonomic instability, and altered mental status. More unique to serotonin syndrome is the presence of GI upset, hyperreflexia, and nystagmus. As in our previous case, the workup should be quite broad until all other causes of the halt and altered patient are ruled out. But be sure to include an ECG, as SSRIs can result in QT prolongation and torsades. Also be sure to send a urine to check for myoglobin due to the hyperthermia and rigidity. Treatment of serotonin syndrome is also mainly supportive with IV fluids, pressors, and bicarb for a widened QRS. External cooling should be initiated for hyperthermia as in NMS. Cyproheptadine is an antihistamine with properties as a serotonin antagonist. It can be used as an adjunctive therapy for serotonin syndrome, but like bromocriptine, it also must be given orally. Our questions for you to finish reading round are the following. 1. What do benzodiazepines treat in NMS? 2. List 3 methods of external cooling. And 3. Explain 3 possible reasons for hypotension in a patient with serotonin syndrome. And that's it. Thanks for watching.